having already joined the meeting today. I don't know if all of you can see my slides and if you can hear me clearly.
Yes, Ruth.
Okay, thank you.
Can see the slides, yeah.
Okay, perfect. So welcome to the Refresher Vaccinology webinar series run by as part of the annual African Vaccinology course, and for its alumni. You'll probably be aware that this is running over a number of weeks, and this is the second of the webinars that we are running. So I just want to welcome all of you, and let me just check how many people have joined in now. I think we've got about 20 people have already joined now, and all of you would know the annual African Vaccinology course, SUI's alumni. It's been running for over a decade, almost close to 2 decades now. And this is a course that, apart from giving content to clarity and understanding of the vaccinology space, it also goes into basic sciences, but also builds chances for networking amongst people who practice vaccinology in the African continent, which is what we would like to encourage, even with these webinars that we're running now. We deal with challenges that are related to immunization. We deal with basic epidemiology and immunology, issues of surveillance, and also how to engage with the media as well as the community, which has become very important in this anti-vaccine climate that we live in right now. So the reason we're doing this refresher course, as you can see by that quote in the bottom there, is that there is a real thirst and a need for people to have this kind of refreshers. As you would know, people would have done this over a very long period of time, and things change. There's new information, and I think you'll also hear as people are talking how much things have changed, and specifically we'll touch on things that are changing every day that are part of the themes that we'll touch as we go. And there's a need to reinforce, even as people refresh their memory about understanding in the field of vaccinology. And again, what I mentioned as the last thing that the VAC course, our annual vaccinology course has been doing this time, this idea of networking, sharing knowledge, sharing best practice, and hopefully this will come through when we have question and answer sessions. So that is basically that. And so the program for today, it's got 3 main presentations, and then we'll have the last part being a question and answer session. And you can see those. There will be basic principles of immunological responses, and then history and rationale of vaccination. I will touch a bit on evidence-based vaccinology and how that applies in the case of a rapidly changing world. And then the 3 speakers will come together and sit for a question and answer session. So as a result of that, we'd like to encourage you to please write down your questions for the presenters using that question and answer function that you'll be able to see on your screen. They will be presented at the end, and then and they will form part of the basis for the discussion. So really welcome to today's session, and really hoping that you'll have a good time, apart from learning and refreshing your memory about aspects of vaccinology. Thank you very much. I'll hand over to Eliza, who will introduce herself as she continues to present. Thank you.
Hi, just give me 1 second to share. Okay, are you seeing on the full screen?
Yes, Eliza, thanks. Yeah,
okay. Thank you so much, Shastani. Hi, good afternoon, everybody. My name is Eliza Nemes. I'm an associate professor at the South African TB Vaccine Initiative at the University of Cape Town. And I'm going to give you a bit of a refresher on immunology. So the immune system hasn't changed. It's still composed of different parts of our body that protect us from pathogens, essentially, which can be transmitted by air, contact, water and food, or from the blood through a lesion. So our protection against these germs has different layers. So the skin and the mucosal surfaces, of course, separate inside of our body from the outside. But then the immune system is composed by different organs, cells, and molecules that these cells use to talk to each other. And it's a fairly complex system, and that's maybe why not so many people like immunology. So zooming in onto some of the main cellular components of the immune system, we have a very broad distinction between the cells that you see here on the left, which are mostly myeloid cells and natural killer cells, which belong to the innate immune response. And the basic features of innate immune response is that it's very quick. It's not specific for the most part to a certain pathogen and does not remember. This again, I'll show you that that's not always the case, but generally speaking, innate cells will respond to pathogens always in the same way or in a very similar way, with exceptions, of course. Then on the right-hand side, you see B and T lymphocytes, which are the cornerstone of adaptive immune responses. Once they're triggered the first time, the response is fairly slow, but it's very specific. And we'll talk about this a bit more. And the most important feature that we exploit in vaccinology is that they remember. So they don't respond in the same way the first time that they see a pathogen and the following times that they see a pathogen. Just a tiny bit of nomenclature, so everything is clear for everybody. When we talk about antigens, we talk about any structural substance that is recognized by the immune system, specifically by B and T cells. And we broadly distinguish self-antigens, which means that they are components of our own body, and they generally don't induce an immune response, or they shouldn't. When they do, we look at autoimmune disease. And we distinguish them from non-self antigens, so structures that come from outside the body, which are mostly protein and polysaccharides, which do induce an immune response. Within each antigen, there are several epitopes. So specifically, an epitope is the portion of an antigen which is recognized by the immune system. And we will see that different people recognize different portions of the same antigen, and different cells recognize different portions of the same antigen. So when we talk about acquired immunity, there are broad distinctions. So you have natural immunity, which is acquired through normal experiences, and this can be active immunity, and this is when you are infected with a microbe one time and you develop your own immune response. It can also be passive immunity, such as those transmitted from the mother to the child through breastfeeding. And then we have artificial immunity. We have passive immunity, again, when, for example, we give antibodies directly to someone, or we have active immunity, which is the consequence, again, of a person developing their own immune response, but the trigger was artificial, in this case, vaccination. So this is really what we focus on when we talk about vaccines. So very broadly speaking, you all know this, but vaccines prevent disease by priming our immune system to fight off infections. And this is too small to read, I know, but I just wanted to give a broad sense that, as you all know, vaccines have evolved over hundreds of years. And I wanted to refer you to this new review, which from Andrew Pollard, which is really great about vaccines in general. And what you can see is that over time, the complexity of the vaccines have increased, but mostly what drove this evolution was, from one side, the understanding of the host and pathogen interactions, which is my personal interest, but also the development of biotechnology. So the technology that we can use today, and of course, here at the bottom, you have the new RNA vaccines, for example, for SARS-CoV-2. Has really evolved from, the very first vaccines where the pathogen was isolated and killed or attenuated and pretty much used as it was, to now be able to really rationally design vaccines to maximize their protection and minimize the side effects. Essentially speaking, regardless of the type of vaccine and that we are thinking about, there are some key concepts that are essentially common to all of them. So every vaccine includes the antigen, and this is the specific pathogen components that we want to induce an immune response against. And this, of course, will define the specificity of such immune response and the breadth. So the breadth means how many antigens or how many components of the same pathogen does the immune system recognize. So in some cases, it could be just one protein, and in other cases, it could be many different ones. Then when we talk about formulation, again, we refer to specifically which vaccine type we're using, if it's live attenuated, subunit, RNA, and so on, which diluent, so the chemical formulation of it, and the dose, which is very important, at which is administered, so how much do we give. And the formulation will essentially determine the quality of the immune response, so which kind of immune response, of which flavor of it we're going to induce, the magnitude, it means how big this response is going to be. And then delivery also is essential, and this ties in nicely with the next two talks for today. So the immunization schedule, the route of administration, and considerations for age and special groups are all essential parts of immunization and will determine the longevity of the immune response and the effectiveness of the vaccine. So what type of immune responses are we talking about? Again, we have innate immunity. As I mentioned, the most important ones for vaccines are macrophages and dendritic cells. Their job is to recognize molecular patterns of microbes, and they communicate danger to other cells. Essentially, they induce inflammation. And what critically they do is that they process these antigens and present them to adaptive immune cells in a way that they can see it. The adaptive immune cells can be cellular, can correspond to the cellular immunity, which is mediated by T lymphocytes. These recognize specific antigens on antigen-presenting cells, which are your innate immune cells. And they have two essential jobs. One is to kill infected cells, and that's mostly CD8 cells, or they orchestrate broader immune responses, and those are your helper T cells. Humoral adaptive immunity is mediated by B lymphocytes. They also recognize specific antigens, and their main job is to produce antibodies. So this diagram illustrates broadly how an immune response is induced by vaccination, and then we'll zoom in on the different steps of it in the next few slides. So here, typically a vaccine is injected in the skin or in the muscle, and the vaccine antigen and the adjuvant, I'll get to it in the next slide, they will activate dendritic cells, which then differentiate and migrate to the lymph nodes. And in the lymph nodes, they present the antigen to T cells. So CD8 T cells, as we said, they are mostly cytotoxic. CD4 cells provide help to B cells, which can recognize the antigen directly, but they need T cell help, and we'll go back to it also. And they proliferate and they generate memory cells and plasma cells, which are the cells that make antibodies. So a little bit more about adjuvants. So adjuvants are substances that when they are added to a vaccine, they enhance its protection, and particularly they help in decreasing the amount of antigen which is required to activate the immune response, so you can use less antigen in the product. They have better safety compared to live attenuated vaccines, better effectiveness compared to, for example, giving a protein alone, which does not really induce a good immune response. They allow their combination with the antigen allows to lower the vaccine dose, and they are mostly responsible for local reactogenicity at the injection site. So we know a fair amount of the mechanisms, how adjuvants work. I'm not going to go into that detail for you, but essentially they create the so-called depot effect. So they concentrate the vaccine in certain area, and they can activate innate cells through pattern recognition receptors or activation of something called inflammasome. And the way, what's more important for you to remember is that these adjuvants can activate the innate cells in different ways, and this will shape which kind of adaptive immune response you're going to get with your vaccine. So this is very important because you could direct the immune response down the wrong way if you choose the wrong adjuvant in the product. A bit more on BNT lymphocytes. So they derive from a common lymphocyte stem cell precursor. B cells, they develop in the bone marrow, T cells, they develop in the thymus, and both of them, they would then recirculate between lymphoid tissues and the tissues. What's important and critically important about these cells is that they have receptors that recognize or bind antigens which are specific to each individual pathogen, and this looks a bit like a key in a lock. But there are important differences. So B cells can recognize the antigens as they are, so in their conformation, while T cells only recognize linear epitopes. So this antigen needs to be processed and presented by other cells, so the antigen presenting cells. So T cells will not activate by themselves, while B cells will. Regardless, after this initial antigen binding, so here you see a T cell will see the antigen only if presented by an antigen presenting cell, while the B cell will see it by itself. What they do is they become activated and they proliferate. Now you can imagine that if every B and T cell only has one receptor specific for one epitope, the naive cells, so the ones that have never seen the antigen again before, they are very, very rare. Otherwise, our body will basically be a bag of T and B cells. So once these naive cells recognize a specific epitope, what they do is that they proliferate a lot to make clones, so cells that are genetically identical to themselves. And after this clonal expansion, the cells also differentiate into effector cells, which generally are the ones responsible for immediate protection, and memory cells, which are the cells that confer long-term protection. So for both B and T cells, but this figure shows B cells, we distinguish primary and secondary immune responses to antigen. As I mentioned before, these are not the same. So in the case of B cells, when a naive B cell sees the antigen the first time, it takes a while for it to proliferate and differentiate and start making antibodies. And there are different classes of antibodies that do different jobs. I'm not going to go into any of those details, but just to know that the first wave of antibodies are generally IgM, and then they are followed by IgG over time. And this is called class switching. So a B cell, as they mature, they change the type of antibodies that they can produce. And then you also have slight changes in these antibodies that increase their affinity or how well they bind to the antigen as the cells mature. So what happens is that with vaccination, we try to induce this primary immune response, because the next time B cells are exposed to the same antigen through a real exposure to the pathogen, the time it takes to produce more antibodies is much shorter compared to the primary immune response, and the flavor of this response is different. So because these antibodies have matured already, you have IgGs, which are better than IgMs in fighting off most pathogens. And then you have a better affinity of these antibodies for the antigen, and you have more antibodies. So the magnitude of this response is bigger. Antibodies have very many different roles. They have this funny shape. The top here is the variable part that recognizes antigen specifically. And then you have a constant part, which is also very important. And antibodies play different roles in response to different pathogens. We are probably all familiar with the neutralization. So they bind to microbes and toxins and prevent them from engaging or interacting with our cells. They can opsonize, so they can cover microbes that then are phagocytosed or eaten up by innate cells. They can induce, they can specifically direct natural killer cells to specifically kill infected cells or bugs themselves, and they can activate the complement, which then brings to the lysis of microbes, and they can also enhance phagocytosis and inflammation. Broadly speaking, there are two types of B cell antigens. There are the T-dependent antigens. These activate the B cell through the B cell receptor. That's what BCR stands for. But they depend on additional signals from helper T cells to activate and differentiate B cells. These are generally protein antigens because they are recognized by both B and T cells. T-independent antigens, they can activate B cells without the T cell help. These are generally the bacterial polysaccharides that T cells don't recognize, but the issue is that they induce a polyclonal B cell activation and poor memory. So most pathogens will contain both T-dependent and independent antigens, but only the T-dependent antigens can induce memory B cells. So why am I telling you all of this, and how have vaccine developers used this concept? This is just a figure showing the same thing. So here you have a polysaccharide that can activate a B cell. These B cells will make antibodies, but does not produce memory B cells. This antibody production is short-lived, so it doesn't last very long. These antibodies do not mature their affinity, and generally, these type of responses are very bad in children, are very bad in the sense that children don't develop these kind of immune responses very efficiently. So what people have thought was to conjugate this polysaccharide with a protein. And these are the conjugate vaccines, and they are really smart because the B cells are also antigen presenting cells for T cells. So what the B cell will do, it will bind specifically the polysaccharide, it will process the protein carrier and present that to a T cell. So the T cell doesn't know that actually the B cell is specific for the polysaccharide, it doesn't care. But once it's activated, it provides help to the B cell that is specific for the polysaccharide to induce affinity maturation, memory B cells, long-lived antibody production. And generally speaking, these vaccines induce very nice immune responses in infants. So for T cells also, there are different types and they have different functions. And I'm not going to go into any of these details, but what's important to know is that different types of T cell responses are geared to respond to different classes of pathogens. So some respond to viruses, some to extracellular bacteria, intracellular bacteria, fungi, and so on. So from the vaccinologist's perspective, knowing which kind of immune response is appropriate for a certain pathogen help us designing better vaccines which are tailored and rationally developed to induce that response. Because if you want to, for example, develop a vaccine for an intracellular bacteria like tuberculosis, on which I work, it will not be very useful to induce like a T-cell response that will induce antibodies of the class that you would need against a worm. So understanding this is actually quite important for rational vaccine design. Immunological memory for T cells is similar to B cells with some differences. Here again, you see that during the primary immune response, that's what we try to induce with a vaccine. It takes a certain time, and then you have expansion of these T cells. But the secondary immune response is faster, so you can have a T cell response much quicker, is stronger, so the magnitude or the amount of T cells that are specific for that antigen is higher, and it's better in the sense that the T cells have learned how to differentiate into the kind of cells that are useful for that pathogen. So there are very many different types of T cells in terms of their differentiation and their location. So while B cells can basically sit tight and pump out antibodies that then diffuse in different parts of the body, T cells need interaction with target cells. So we find them in lymphoid tissues, and these kind of patrol, they just taste the blood and see, or the lymph better, and see which pathogens are around. But then when they get activated, they migrate to peripheral tissues, which is where infections occur, and some are even tissue resident. What's important to remember, the only thing that's important to remember here is that as T cells differentiate, they lose proliferative potential, which is what's essential for a good memory response, so a recall response many years later, but they acquire effector functions, which are the ones that are important for immediate protection. And the initial exposure to the antigen in terms of the load, so how much antigens these cells see and for how long they're stimulated, basically drives T cell differentiation. So again, I hope you see that playing with the type of vaccine and the dose and the schedule of immunization, we can try and skew this T cell memory in the way we would like it to be. As I mentioned earlier, generally we think that innate cells don't have memory, and here is just a summary of what I just told you about adaptive immune memory, which is based on clonal expansion of antigen-specific cells, which then generate long-lasting memory cells. But in the last few years, there have been quite a number of studies showing that some innate cells, in particular monocytes and maybe NK cells, they do share some of these features. The mechanism is not the same, but after a first challenge or a first exposure to a pathogen, these innate cells undergo metabolic epigenetic reprogramming, which results in enhanced effector function after a second challenge. Now, what's important is that the first and the second challenge don't need to be the same for innate cells. So you can prime, if you wish to use that term, with one pathogen and see enhanced response against another. So the bottom line here is that immunological memory is not exclusive of B and T cells. And secondary immune responses involving innate cells can be triggered by a wide variety of stimuli. This science is right just at the beginning, so we don't know very much about this. But what's key and very intriguing is that this trained immunity of innate cells may explain some of the non-specific effects of vaccines. So we've talked about memory, but so how long does this memory immune response last? Well, it depends, like everything. Some vaccines will induce lifelong immunity, and some vaccines will induce waning immunity. And these depends on a variety of conditions. The vaccine type, for example, live attenuated vaccines are really good at inducing lifelong immune responses, such as yellow fever, for example. But also it depends on the immune response that's induced, whether there is natural exposure, which basically works as a recall response, and then the population and the environment. What's important programmatically is that for the vaccines that induce a memory response that wanes over time, we need boosting. And everything we've talked about until now was the priming event. So how do vaccines induce a first immune response? But then if we use the same vaccine again, to just wake up all these memory cells, proliferate a bit more, and let's say keep the levels up. That's what boosting does. And traditionally we use the same vaccine for boosting, but some of the new concepts that I'm sure you've heard also about COVID is heterologous prime boost, which is where you use one type of vaccine for priming and another type of vaccine for boosting, but of course kind of the antigen needs to be the same. The immune response evolves over time, and it's very different. Our immune system is very different when we are born compared to when we are adults, and then when we age. So there are age-specific considerations that are driven by what we understand of the immune responses or the limitation or weaknesses of immune responses at extremes of age, which again, are taken into account where, for example, decisions are made in terms of the vaccine dose and how many injections we give, because the approach might well be different at different ages. Another very important aspect is to direct the immune response where we want it. So for many infections, it doesn't matter. What you want is basically a systemic immune responses, but for some other infections, it's maybe appropriate to direct the immune response where it's needed. So if you think about polio, for example, you rather want a good immune response in the gut mucosa, or if you think about tuberculosis, you may want a good immune response in the lung. So this can be part
Have we lost you, Lisa?
It seems we may have lost Lisa. I think the problem may be I think maybe the load shedding or something of the sort. Can everyone still see me?
Yes,
we can. Okay. I'm just going to check and see.
Nena, I don't know if we can try to just check on the outside what's happening with her, and then
Okay.
maybe we can see if I think she still had about 7 to 8 minutes on her talk.
Ruth,
Yeah.
sorry to jump in. I'm in touch with her on WhatsApp. She's trying to reconnect.
Okay, thanks. Thank you.
Hassan and Rutani, I've gotten a message from Elisa saying that she is having some difficulty with reconnecting. So maybe we can go to the next speaker, and once she is able to sort out the technical challenges, she will finalize our talk at the end.
Okay, that's fine. Let's go on to, is it Karin who's next?
Yeah.
Yes, I think it's me who is next. Thank you very much, and thank you to VACFA for inviting me to give a presentation in the refresher webinars. Let me try to share my screen.
Yeah, we can see it,
Yeah,
Karin.
you can see it. Yeah, thank you very much. So yeah, my name is Karin Dorcher. I'm from Belgium. I work at the University of Antwerp, where I'm responsible for the Network for Education and Support in Immunization. And we have a long-term collaboration with VACFA, so it's always a pleasure to meet them online now. So thank you very much for inviting me. I will briefly give an update on the history and rationale of vaccination schedules. The outline of the presentation is what is the rationale of vaccination schedules, the scientific and policy evidence related to the vaccination schedule. We will look at a few examples of changes in the vaccination schedule over time. We will look at a few countries at their vaccination schedules, alternative schedules which we should not be doing, and then I will close with 2 words on the life course approach to immunization and then conclude. What is a vaccination schedule? A vaccination schedule is a schematic of the ideal timing of administration of 1 or more vaccines based on the best opportunity to provide protection and minimize risk in the prevention of vaccine preventable diseases. So why are vaccination schedules important? One, for programmatic reasons, as it gives a framework for delivery of the vaccines to the target population. Secondly, we can measure the evaluation of the coverage of the vaccination, so we can see if the vaccination program is doing well or improvements need to be made. For research and development, it gives parameters for vaccine studies, and in that respect, we can see that vaccination schedules can evolve over time. And for information and participation of the public, to let them know when the vaccine will be given, how many doses, and when to come back to receive the next dose in the schedule. More than 100 years ago, the vaccination schedule was quite simple. We had 1 vaccine, the smallpox vaccine. And then in the late 1940s, the vaccines given at that time was smallpox vaccine, pertussis, diphtheria, and tetanus, given as DTP. And in the late 1950s, the polio vaccine was added to the schedule. In the 1960s, vaccines were developed against measles, mumps, and rubella. And in 1967, WHO started an intensified plan to eradicate smallpox, and we can see here the number of countries with 1 or more cases per month. And when the intensified eradication program was started, we can see a decline in the cases, and smallpox was officially eradicated in 1979. Now, based on the success of the smallpox eradication program, WHO established the expanded program on immunization in 1974 with the 6 basic vaccines that we all know: BCG, polio, diphtheria, tetanus, pertussis, and the measles vaccine. Then in the early 90s, vaccination against hepatitis B was added to the schedule, and that could be given either as a monovalent hepatitis B vaccine or combined with DTP, and here the hip vaccine, which was added later in 2000. And it is important to mention here that with the arrival of the launch of Gavi, that many countries were able to introduce vaccines against hepatitis B and HIP, and that is often used as a pentavalent vaccine, which is also the backbone of many of the immunization programs. Then there are vaccines for special risk areas like yellow fever vaccine, meningococcal A vaccine. The new vaccines that came on board, rotavirus vaccine, PCV, HPV vaccine, and then very recently COVID-19 vaccine. And all the guidelines evolved and strengthened and focuses on the introduction of new vaccine outlined first in GIFS, GVAP, and then now in the Immunization Agenda 2030. Here, just for information, this is the very first immunization schedule developed by WHO. And we can see here BCG vaccination given at 0 to 4 weeks, at 3 to 9 months smallpox vaccination, and DTP vaccination. So we can see here a very small schedule in the beginning of the immunization program as compared to what we have now. Now, often a vaccination schedule is a compromise between different factors. Evidence-based science is playing a role. The immunology, as we heard in the previous presentation, is the immune system ready to respond to the vaccine? Epidemiological data are important, the burden of disease, which age groups the disease occurs. Programmatic issues play a role, the type of the vaccine, number of doses, can it be easily integrated in the existing vaccination schedule? Cold chain plays a role. Health economist is important, and political factors as well. And what I mean here, for example, is when a country produces its own, for example, hepatitis B vaccine, then of course that country is most likely to use the monovalent hepatitis B vaccine as compared to the pentavalent vaccine, DTP, HIP, and hepatitis B. So the age of vaccination depends on the risk of disease, the risk and severity of the complication, the maturity of the immune system, potential interference by passive maternal antibodies, and also vaccine safety and reactogenicity. And vaccines are usually recommended for the youngest age group at risk for experiencing the disease, for whom efficacy and safety has been demonstrated. So here we can see the schedule for developing the schedule for the primary series in infants. Here the age, we see the risk of infection, the maternal antibodies that decline over time, maturation of the immunological immune response, and then here the opportunity to vaccinate. So these are all the things taken into consideration when developing your schedule for the primary series in infants. Then spacing of multiple doses of the same vaccine. We heard in the previous speaker that some vaccines induce a protective antibody response after 1 dose. However, most vaccines require administration of multiple doses in the primary series. Intervals longer than recommended between doses do not impair the immunological response. Because of the immunological memory, and also the interruption of a recommended primary series or an extended interval between booster doses does not require restarting of the entire schedule. Allowing at least a 6-month gap between the last primary dose and the first booster dose allows for completion of the affinity maturation process. And as said, vaccination schedule try to achieve a balance between early protection and best immune response by spacing out vaccines enough to allow immune maturity, but early enough to protect before acquisition of the disease. And of course, adherence as closely as possible to the recommended schedule will ensure optimal protection. Then now we will look at a few examples. First, we will look at the measles vaccine. And there the timing of the vaccination, as we know, depends on the rate of the disappearance of the maternal antibodies and the risk of exposure to the measles virus. So at burden in the first 6 months of life, most infants have passive immunity because of maternal measles antibodies. The current recommendation for measles vaccination is reaching all children with 2 doses of the measles vaccine. And the second dose is really a primary series, it's not a booster dose. So the second dose of measles is recommended to induce immunity in children who failed to mount an immune response to the first dose. When the risk of measles mortality among infants is high, the first dose of the measles-containing vaccine should be administered at 9 months of age. And then the second dose could be administered at the age of 15 to 18 months. And the minimum interval between first and second dose of measles-containing vaccine is 4 weeks. In countries with a lower risk of measles infection among infants, the first dose can be administered starting at 12 months, as higher seroconversion rates are achieved at 12 months as compared to 9 months. And we can see that here in this slide, when we look at the seroconversion rate at 12 months, we see close to 100% seroconversion rate. When we look at 9 months, about 85% seroconversion rate, and looking at 6 months, even lower seroconversion rate. Now, what is also being observed is that waning of the maternal antibodies is faster when the mother was vaccinated. That you can see here as compared when the mother had a natural infection. So maybe that might change the schedule over time, taking this into consideration. Now, currently, the position of WHO is that a supplementary dose of measles-containing vaccine can be given to infants from 6 months of age in specific circumstances. Now, if the dose at 6 months is given, it should be recorded as dose 0, MCV 0, and those children should also receive MCV 1 and MCV 2 at the recommended ages according to the national schedule, unless the country has data showing that there is indeed a high seroconversion rate when vaccination is carried out before 9 months of age. And when we look here at the coverage of the first dose of measles vaccination, we can see here, so the darker colors, blue here, have a good coverage, and we see here that the African region has a lower coverage of the first dose of measles vaccination, and those are the countries starting vaccinating at 9 months. And when we look at the second dose, it's unfortunately the same region where there's a low coverage of the second dose of the measles vaccine. Then briefly going to hepatitis B, we all know that when you are infected at birth or early in life, you're more likely to develop a chronic infection as compared when you get infected at an older age group, you are more likely to have an acute infection. So here we can see the regions with the prevalence of the S antigen, and the higher regions here in the darker colors where I have a prevalence above 8%. And we also observed that when the mother is S and E antigen positive, the majority of the infants become infected. And again, the majority of those infected infants become chronic carriers, as mentioned in the previous slide. When the mother is only S antigen positive and E antigen negative, only 10% of those infants become infected, and 90% of those infected infants will become chronic carriers. So there is really a need for a hepatitis B birth dose. The recommended schedule earlier on was at 6, 10, and 14 weeks at the same time as other vaccines. And then it was recommended that a birth dose is included in the vaccination schedule. So that gives then 2 options, either a monovalent birth dose followed by 2 monovalent or often a combined vaccine at the same time as DTP1 and DTP3 doses. So here you have a 3-dose schedule, or you use a 4-dose schedule, a monovalent birth dose followed by 3 monovalent or the combined vaccine doses at the time of DTP1, 2, and 3. So that depends here on your programmatic issues for each national program. Currently, no recommendation for booster dose, and if catch-up vaccination would be considered, the priority should be given to the younger age group, since the risk for chronic infection is highest in those cohorts. When we look at the coverage globally for 3 doses of hepatitis B vaccination, global coverage is 85%. And here you see the coverage for the different regions. The African region coverage of 73%. And when we look at the coverage of the bird dose, globally 43% coverage, the African region coverage of 6% of the hepatitis B bird dose. Then the third example I would briefly like to discuss is pneumococcal vaccine, PCV vaccine. And WHO recommends 2 schedules. 3 primary doses plus 0 at 6, 10, and 14 weeks, or 2, 4, and 6 months, or an alternative schedule of 2 primary doses plus 1 booster dose, where then the booster dose is given between 9 and 18 months. And when you have high incidence of pneumococcal disease, then 3 primary doses are recommended for fast protection. When you have a lower disease burden, it's better to move to 2 primary doses plus a booster dose, as that would increase your duration of protection. And here, if the two primary doses plus 1 schedule is used, an interval of 8 weeks or more is recommended between the 2 primary doses, and then the booster dose should be given at 9 to 18 months. Then I briefly want to go to the UK. Their PCV schedule was 2+1 schedule. First dose at 8 weeks, then second dose at 16 weeks, and a booster dose at 1 year. And they introduced PCV7 in 2006, and then moved to PCV13 in 2009. And we can see a decline of the PCV7 serotypes, and also a decline here in green of the PCV13 serotypes. So the IPD incidence due to the PCV13 serotypes has remained stable since 2013-14, as we can see here. And for that, they have changed their schedule now to a 1+1 schedule, actually. So moving from a 2+1 to a 1+1. That they believe that provide individual protection and maintain herd protection against pneumococcal disease. And of course, it reduces the number of injections that each infant receives and makes space for new vaccines in the immunization schedule. The basis for their recommendation is summarized here with the different papers. I just want to briefly go to a table here, a randomized controlled trial that showed that post-booster serotype specific antibody responses were similar following a 1+1, so the new schedule, and a 2+1 schedule in infants. And that we can see summarized here. So post-primary group 1, 2 months, 4 months, the second group 3 months, so the 1 dose, and here the post group, the 3 doses, 2+1, and here the 1+1. And 9 of the 13 serotypes in PCV13, the post-booster responses in infants primed with a single dose are equivalent or superior to those seen in the standard 2+1 dose. And here we can see in red, I've highlighted the ones that are superior, and in blue, the ones that are equivalent. So based on these data, of part of these data, the UK has decided to move to a 1+1 schedule. Then briefly going to rotavirus vaccination, which is a nice example where the safety of the vaccine is very important. The first rotavirus vaccine, RotaShield, was licensed in 1998 and already withdrawn in 1999 because of an increased risk of intersusception. So based on this experience, the new rotavirus vaccines that were developed, Rotarix and Rotatec, a strict age restriction was adhered to in the beginning. The first dose should not be given after 15 weeks of age, and the last dose here, the second dose, and in case of Rotatec, the third dose should not be given after 32 weeks of age, and no booster vaccination given. So based on this intussusception, then when looking at the data, if you really adhere to these strict age restriction on the first and the last dose, then many children will not be vaccinated if it is given at the same time as DTP or the pentavalent vaccine. If that vaccine is given late and the rotavirus vaccine could not be given, so many children missed out on the vaccination for rotavirus vaccine. So by allowing infants to receive the rotavirus vaccine together with the DTP, regardless of the recommendation time of DTP vaccination, children will be reached who were previously excluded from the benefits of rotavirus vaccine. So therefore, WHO released these strict age restrictions to give it together, rotavirus vaccine together with DTP or pentavalent vaccine, but it is not recommended rotavirus vaccination above 24 months of age. And here are some data on modeling from many low and middle income countries. Based on when you see no vaccine given, the number of rotavirus gastroenteritis deaths, and here the number of intussusception deaths. When you apply an age-restricted scenario, so really not the 15 weeks for the first dose, 32 weeks for the second dose, when you really apply that, you see here the number of averted versus no vaccine, and a reduction in deaths versus no vaccine, 32% reduction, and intussusception death, an increase of intussusception deaths compared to no vaccine, 0.8%. When you do it with the unrestricted scenario, so you can give the rotavirus vaccine up to 24 months of age, you can see here the number of the deaths and the number averted and the intussusception deaths. When you do the comparison age unrestricted versus age restricted, we see that the benefit risk profile is positive in these countries given, and therefore the age restriction can be released. And so that was very clear in this publication. And what was also interesting, they looked also at different schedules, so not the schedule that we know at 6 and 14 weeks, but also at different types of neonatal schedules. And they also have the potential to prevent more rotavirus gastroenteritis deaths and cause fewer excess intussusception deaths than the currently recommended schedule. And the schedule that came best out of this modeling was the first dose given together with BCG and the second dose with DTP1. So this is currently not a recommendation. This was a study, but who knows, maybe in future the schedule for rotavirus vaccination might be updated. So currently the rotavirus vaccines currently available are considered safe and well tolerated. And we all know the Rotarix and Rotatec, and 2 other rotavirus vaccines have recently been WHO pre-qualified in a 3-dose schedule. These vaccines have a low risk of intussusception, but of course should be alert for any signs. Then the last vaccine I briefly want to talk about are the HPV vaccines, and we all know the 3 vaccines available: the bivalent, the quadrivalent, and the 9-valent vaccine. And we give the vaccines they are recommended at 9 to 14-year-olds, and here you can see the immunological basis for that reason. When we look here for the bivalent vaccine at the GMTs for HPV 16 and 18 in two age group, in red 10 to 14 years old and in yellow 15 to 25 years old, we see that the immune responses is much higher in the younger age group. So therefore, recommendation to start vaccinating at an early age from 9 years onwards. And this is for the bivalent vaccine, and we see similar pattern for the quadrivalent and the 9-valent vaccine. Originally, the vaccines were licensed in a 3-dose schedule, and randomized controlled trials were done in 15 to 26-year-old women, and trial endpoints were the cervical precancer lesions, and the efficacy against vaccine type endpoints was over 96% in the protocol analysis, and seroconversion after 1 month after the last dose of the vaccine was close to 100%. And then immunobridging studies was done in the younger age group, 9 to 15 years old. So the licensure in this age group is based on the non-inferior antibody response compared with that in young adult women in efficacy trials here. Now, there is, of course, a global interest in simplified schedules for the HPV vaccines, reaching adolescent girls with 3 doses. It's an expensive vaccine. So clearly there was interest as it could facilitate implementation, reduce the logistical challenges, decrease the cost, and it might increase the acceptability for the healthcare workers, the parents, and the girls. So the interest in evaluating a 2-dose schedule in young adolescents stimulated by the data from clinical trials with the 3 doses. So in those randomized controlled trials, not all individuals completed a 3-dose schedules, and when those women were also being followed up, an efficacy against incident persistent infection 16-18 was similar for 3, 2, and 1 doses. Regarding immunogenicity, non-inferiority immunogenicity studies conducted to evaluate 2 doses in 9 to 14-year-old compared to 3 doses in 15 to 26-year-olds. And the seroconversion and geometric mean titers were non-inferior in the 2-dose group compared with the 3 doses in the women aged 16 to 26 years of age. It was recommended, however, to have a 6-month interval between the 2 doses, as there was loss of non-inferiority in the 2-dose schedule when it was given 2 months apart. And then WHO recommended the change of moving to 2 doses for persons aged 9 to 14 years of age. So these are the current recommendation, a 2-dose schedule with a 6-month interval for girls 9 to 14 years old, and the 3-dose schedule, so the original schedule over 6-month times, remains recommended for girls above 15 years of age and for immunocompromised individuals. Now, what about the 1-dose schedule? So the same studies that stimulated an interest in a 2-dose schedule led to interest in a single-dose vaccination. Non-inferiority immunogenicity studies are not possible because a single-dose HPV vaccination results in lower antibody titers compared to 2 or 3 doses. At the moment, there is still no correlate of protection, although it seems that very low levels of antibody are thought to be protective. So efficacy studies are needed for the evaluation of a single-dose vaccination. And this is a summary of different studies and trials that are ongoing. And you can see here the timings for interim results and final results. And just to highlight a few from this table, here the bivalent vaccine that was in a randomized controlled trial in Costa Rica, women 18 to 25 years of age. And as just mentioned earlier, not all completed the 3-dose series, sorry. Oh, yeah. So here we see the women completed the 3 doses, 2 doses, and 1 doses. And when we look at the vaccine efficacy, it is similar, and that after 11 years of follow-up. And we see the same for the trial in India with quadrivalent vaccine follow-up after 10 years. Again, 3, 2, and 1 dose high vaccine efficacy for 1 dose as well. And here is one of the new trials that is being set up here in Kenya, where the 9-valent vaccine is compared with the bivalent vaccine, and the control, they use the meningococcal vaccine in a 1 dose. And we can see the incidence persistent infection, 1 case in the non-valent arm, 1 bivalent, 36 meningococcal. And when you do the comparison, so the vaccine efficacy for the 9-valent, 97% efficacy for 1 dose, same for the bivalent vaccine. This for HPV 16 and 18. And when looking only at the 9-valent vaccine, looking at the 7 types included, we see a vaccine efficacy of 88%. At the SAGE meeting just now in April, they discussed all these data in detail, and they will make a new recommendation. And I read it here from the summary from SAGE. SAGE advised that countries may now choose between a 1 or 2 dose schedule for 9 to 14-year-olds. This off-label single dose option for routine and multi-age cohort catch-up vaccination was considered because it provides comparable and high levels of individual protection, while from a public health perspective being more efficient, less resource intensive, and is easier to implement than a 2-dose schedule. And similarly, either a 1 or 2 dose schedule may be applied for young women aged 15 to 20 years old, while 2 doses with a 6-month interval should be used for females older than 21 years. So clearly, the schedule for HPV vaccination is evolving over time. I'm almost done. Combination vaccines, we all know the importance of that, and we can see here in the graph if all vaccines should be given in a single injection. Then in 2007, the poor child had already 23 separate injections, and of course the advantages of combination vaccines, we all know them. There are many, but what I would like to highlight here, a better coverage with fewer injections. We can see the coverage of DTP3 close to 80%, hepatitis B also close to 80%, but when we look at HIP, we only reach 50%. So if a combination vaccine, the pentavalent vaccine, would have been used, the coverage of HIP would also be at that level. Then this is a summary of the WHO schedules, the summary tables, and we have, you can look at it at your own time, and they have discussed most of them here. And then looking briefly at a few schedules here from South Africa. At birth, South Africa gives BCG and OPV. Looking PCV, for example, at 6, 14, and then 9 months, so a 2+1 schedule. They use an hexavalent vaccine at 6, 10, 14 weeks here, including DTP, IPV, HIP, and hepatitis B. And what is interesting, what we discussed in the beginning for measles, they give the first measles vaccine at 6 months, and then the second dose at 12 months, and then they also include HPV vaccination. In Flanders, in Belgium, we start only at 8 weeks vaccination. We don't give any vaccines at birth. We also use the hexavalent vaccines as shown here. For PCV, we also use a 2+1 vaccination schedule. For measles, we use the MMR vaccine, first dose at 12 months. The second dose at 10 years, but because of increased measles outbreaks everywhere, this is moving forward in age groups, meningitis C, and then we also give at this stage still 2 doses of the HPV vaccine. Here, I got these data from the WHO website. So in case it's not complete, my apologies, and please highlight it in the discussion then. For Kenya and Nigeria, we see this, it's quite similar, starting at birth, BCG and OPV, and Nigeria also give hepatitis B. The pentavalent vaccine with whole cell pertussis is being used in both countries. Kenya uses the MR vaccine, Nigeria measles vaccine. HPV vaccine is introduced in Kenya, and yellow fever vaccine subnational. IPV dose recommended at 14 weeks, and then 3 primary doses for PCV and then rotavirus, and that is 3 primary doses in Nigeria for PCV. Oops, sorry. No rotavirus vaccine introduced, although is planned for introduction. They also use vacc against meningitis at 9 months and yellow fever. And here for Somalia and Gabon, unfortunately, not all countries are able to do as good. We see BCG and OPV at birth, 6 and 14 weeks, a pentavalent vaccine, and only 1 dose of measles vaccination in both countries, and no introduction yet of PCV and rotavirus vaccine. So we see a variation between the different countries in their schedule. And here is a summary of the primary schedules in the world. Here in yellow, they are using the 6, 10, 14-week schedule. In light blue, starting later at 8 weeks, so the 2, 4, 6 month schedule. And we see here in the dark blue, mainly the Scandinavian countries who actually use a 2+1 schedule. It is, of course, important with the schedules to vaccinate on time. And here are data from the US showing that on-time vaccination only occurred in 26% of time, and on-time vaccination is given the vaccine within the month. We see that delayed less than 6 months, 37%, and delayed more than 7 months, also 37%. So it is really important to stick as close as possible to the schedule, to the recommended schedule of your country. And what we should definitely not do is intentionally follow an alternative schedule. So not because the vaccine was unavailable or there is an illness, but really an intentional following an alternative schedule. As here the example in the US, where 25% of the children in this study followed intentionally an alternative schedule, meaning that they had 2 extra visits compared to children who followed a routine schedule, and they were also less likely to be up to date at 9 months as compared to those following the routine schedule. So this leads to, as we all know, poor vaccine coverage, leaving the children vulnerable to infection and increase the risk of outbreaks. Then to close off, we have gone through different vaccines, and the schedules is becoming more complex as more vaccines are being added. And now we are moving forward towards a life course approach to immunization, so making the schedule even more complicated. And we are vaccinating pregnant women, already TT vaccination, the newborn infants, the 2nd year of life with the booster doses, the child 2 to 8 years, adolescents 9 to 19 years, we discussed HPV, adult vaccination, where the healthcare workers fall in this category, and the older persons. And here we can see the status of the different regions for these different groups that actually have a recommendation for these different stages. And we see that most regions recommendation for pregnancy, newborn, infant, and child. But when we look at adolescent, adults, and older persons, we see that recommendations really vary between the regions. Yeah, I stop here. So we have seen that immunization is an evolving science. The schedules are not set in stone, as we have seen with 4 or 5 examples. Given the differences in epidemiology, health infrastructure, and resources, it will be difficult to develop a single immunization schedule for all countries. of course, optimizing the schedules could reduce cost and streamline their integration with other vaccines. WHO has recommended vaccination schedules, and they are very useful, particularly in low and middle income countries. Of course, it is important to adhere to the national recommended schedule, and we are now moving forward to the life course approach to immunization. So thank you very much.
Thanks so much, Karin. So we are, again, I think for all the participants, going to do all the presentations, and then we will have a discussions section. So Elisa unfortunately missed out on finishing her presentation, so we're going to let her just finish off her presentation, and then we'll go to Ruzani. So Elisa, back to you.
Thank you, Hassan, and I'm really sorry. My connection just dropped. But the good point is that I finished the main part of the talk, and I think it's kind of timely to talk about correlates of protection now. You've heard some examples I will refer back to. So just to recap, so the point of vaccination is to prevent disease by priming our immune system to protect against infections. But when we talk about immunogenicity of a vaccine, what does that really mean? Essentially, it means the ability of the vaccine or a substance to provoke an immune response. But is any vaccine-induced immune response protective? And the answer is not necessarily. So you may induce immune responses that are not responsible for protection. So that brings us to the concept of correlates of protection. So correlates of protection are specifically the measurable immune responses that predict vaccine efficacy. As you can imagine, when you vaccinate someone, you will have activation of different types of immune responses, but it does not mean that every single one of them is the mechanism or is responsible for protection. So if a correlate of protection is known, generally we also know what a protection threshold for that measurement is. And the way we can use this information is we can just measure that immune response in the blood and be able to predict whether that person is protected or not. So as I was mentioning before I was talking about waning of memory immune responses, but we have the same issue with waning of protection. So some vaccines will induce lifelong protection, some require boosting, and some will induce no protection, for example, in certain particular populations. A tiny bit more of nomenclature. When we talk about correlates of protection, is different from talking about correlates of risk. Correlates of risks are immune responses that are prospectively associated with the risk of having disease. And this is regardless of vaccine efficacy. So these can, for example, be evaluated in longitudinal case control studies. While on the other hand, correlates of protection are mostly defined in the context of placebo-controlled clinical trials with a clinical endpoint and imply association with vaccine efficacy. Now, what that clinical endpoint is can become fairly tricky. In the case of COVID, as you've heard, and has become very confusing for the public and healthcare worker alike. What the endpoint is it can be different things. You could have a vaccine that prevents infection, for example. You can have a vaccine that does not prevent infection but prevents disease. Others that prevent hospitalization and death. And the way these vaccines were and are tested, you will get different numbers of efficacy depending on which endpoint you're talking about. But why is this useful? Well, Dr. Karim gave us fantastic examples, which I'm going to go back to. But for new vaccines, so for the vaccines that we don't yet have, if we identify specifically which kind of immune responses are responsible for protection, it will enable a more rational vaccine design and development, and provide insights into the host defense against the pathogens and which mechanisms are really important to fight off infections. But for existing vaccines, they will allow you to optimize the vaccination strategy, where, for example, you can test different formulation or delivery or bridging between populations without the need to wait for a clinical efficacy endpoint. And the example on HPV was really perfect for this, because once the immune correlates of protection against HPV was identified in older women, it could be bridged to younger girls just by measuring that correlates of protection and not waiting for them to develop, for example, cancerous lesions, which of course will take maybe another 50 years. And then if you know what the correlate of protection is, that is a true measurement of herd immunity. Just measuring that people have antibodies, for example, regardless of which antibodies they are, it might not actually be informative at all to say the population is actually protected. And of course, COVID examples are many of these concepts. But so from the immunologist perspective, how do we determine what a correlate of protection is? As I mentioned, the gold standard to do this is in the context of placebo-controlled, randomized efficacy trials of new vaccines. But it can be determined also by the level of passively administered or maternal antibodies that protect. Again, as in the case of COVID now, where probably it's not possible to use placebos anymore, you can also derive this from population or cohort studies of effectiveness trials or studies. They can be determined by the reason for vaccine failures. So, for example, in immunocompromised individuals, human challenge studies, these are rare. There are a couple of models, for example, for malaria, where these have been incredibly useful. And they can be extrapolated by animal studies with, of course, limitations, because we need to make sure that what we observe in the animal model actually reflects what happens in the human. So this graph is quite old, but I really like it. And basically it shows what the protective immunity or the correlate of protection is for different vaccines. And here you see antibodies and T cells, and then it's plotted against the antigen stability. In other words, how often the antigens change. And what you can see very clearly is that successful vaccines, they all have antibodies as correlates of protection. There is more about HIV, also the field has shifted, but if you look at the more complex pathogens like malaria and TB, the thinking is that T cells are more important. What's also highlighted here is that the successful vaccines, they are against mostly acute infections, which would induce protective natural immunity by themselves. While for the vaccines that we don't yet have, and where T cells are thought to be correlates of protection, these are against mostly chronic persisting infections, or if not persisting infections that you can get over and over again, like malaria, for example, or TB for what matter, and where the natural immunity is only partly protective. That said, talking about antibodies or T cells is too generic. For the vaccines and the diseases where correlates of protection have actually been identified, it's very specific. It's certain functions of antibodies or a certain functional or differentiation profile of T cells. Is not, again, it's not any antibody. From the lab perspective, it's way easier to measure antibodies because there are standardized high throughput assays to do that, while the assays to measure T cells are more labor intensive and complicated and less easy to standardize. So this means also that when you have a new vaccine or you want to identify correlative protection, everybody tries to find antibodies first, and then there will be some studies on T cells. So maybe that distinction is a bit inflated from the ease of actually doing certain measurements compared to others. And I'm sure everybody's curious about correlative protection from SARS-CoV-2. As you can imagine, there are very many studies ongoing, but there is quite a clear picture coming up. And as it was predicted before it was actually demonstrated, it looks like neutralizing antibodies are really important to protect from symptomatic infection. And this makes sense if you think that the role of neutralizing antibodies is to prevent the virus from actually infecting the cells. So they can prevent infection altogether. But once infection has been established, there are increasing data showing that T cells at that point are important to protect against severe disease and dissemination in the body. And again, if you think about what T cells do, for example, they would kill infected cells. So containing infection and preventing a dissemination. Of course, with COVID, we are in unprecedented territory for many very different things. But when you think about vaccines, never ever have we had so many different products coming into the market or rolled out at the same time. And these products are very different from each other. And it's completely plausible that there will be different correlates of protection induced by different COVID vaccines. So there might not be one universal one. The duration of protection is a question everybody's asking, and there are some data about that. And one issue is when different studies from different developers are all done at the same time, is also that the standardization across endpoints and the samples that are collected and the assays that are done, goes as a second priority. So it's fairly difficult to cross-compare directly different COVID vaccines and the outcomes of different trials if these aspects are not standardized. I still like this sentence from Albert Einstein very much, which says everything should be made as simple as possible, but not simpler. So what I hope you will also take away from this lecture is that vaccine efficacy really depends on many different aspects, which start from the type of vaccine that you use, the dose, the schedule, of course, of immunization, the route of immunization, and then there can be differences depending on the recipients, so different age groups or what the nutritional status is, genetic background, etc. And of course, immune responses play a major role. So an emerging science is called systems vaccinology, really in the acknowledgement that things are complicated. There are many studies over the last 10 years or so, which actually try to acknowledge this complexity and try to consider all these different factors which could come from the environment, genetic background, the microbiome, other comorbidities, and couple all these variables with very, very complex measurements of the different aspects of the immune response and try to analyze the data and model the data to get a bigger picture, specifically for the diseases for which we don't have yet efficacious vaccines. There are many barriers that remain to vaccine development. Of course, I'm mostly focused on understanding immune responses. Sometimes some products have poor immunogenicity, we don't know why. For some diseases, such as, for example, tuberculosis, HIV, and malaria, we don't know what the correlates of protection are. Some individuals have inadequate innate immunity, so even if the vaccine is good, but maybe that priming event is not very good. And for some diseases we lack animal models, and for others we may have animal models, but we don't know how the back translate into humans. And when we think about measuring immune responses, often it happens that, you know, we only access blood, and maybe what we see in the probably what we see in the blood is not necessarily reflective of what is happening in the tissue. Then, of course, we need to consider host variability and the pathogen variability. Again, with COVID, we are all too aware of the different variants and the issues that they may cause in vaccine effectiveness. Safety is obviously a big factor. You heard the case of the rotavirus and the intussusception. So safety always comes first, and then also environmental and geographical factors can affect vaccine effectiveness. And with this, I am really done. Thank you so much, and apologies for the pause in my talk before.
Thanks so much, Elisa. That was really, really interesting. And thanks to both you and Karin for very comprehensive presentations on your respective areas. We're going to now go straight into Rudzani's presentation. And, you know, after that, we'll deal with questions. I see some people have posted questions in the chat, but just to encourage all of you, if you should have questions, I think, sorry, not in the chat, in the Q&A box, please post your questions in the Q&A box. It just makes it a bit easier to process in that way, and rather than in the chat. Rudzani, over to you.
I was trying to unmute myself. Thank you very, very much, Hassan. I did not introduce myself in the beginning when I introduced today's webinar. So my name is Rudzani Mroiwa. I'm a pediatrician based at the Red Cross War Memorial Children's Hospital, as well as being the head of Department of Pediatrics and Child Health at the University of Cape Town. I work with the vacc team as a member of the entity. So what I'm going to talk about is evidence-based vaccinology in a world in which the burden of disease, new infectious diseases occur, and so much can actually change. Nothing is actually at all static. I will try to finish in the not to take too long in this talk, but just remind us again of how evidence actually works in that space and how critical and important evidence is. So this is beginning of 2021. We are in the middle of the second wave of COVID-19 infections in South Africa, driven by a new variant that the world dubbed the South African variant because it was first detected here. This became later known as a beta variant. The cases are increasing. There are a lot of hospital admissions. There were a lot of in-hospital deaths. And in fact, there are fears that the deaths may actually be increased by the hospitals running out of oxygen. It seems somehow that high-income countries have managed to acquire the vaccines for themselves, and they've already started vaccinating in the beginning of January in the UK, and the Russians had already started, I think, in September with their Sputnik vaccine. You know, almost like a phase 3, phase 4 type implementation. So what does South Africa do? South Africa goes out and tries to negotiate with India to get the AstraZeneca vaccine so that we can start vaccinating people quickly. There's a lot of political pressure to make sure that we respond, and there are people writing petitions and so forth. So of course the government does that. Beginning of Feb, the first AstraZeneca vaccines arrive in South Africa. And people like Prof. Mohammed have been involved in this, where people were deciding what the priority groups are, Prof. Hassi and the rest of them, you know, the elderly, and there's a whole step down and a list of who's first, healthcare workers and so forth. A week later, boom, South Africa suspends use of AstraZeneca COVID-19 vaccines after it fails to clearly stop various virus variants. Apparently, the vaccine does not work or does not work very well. It's not, does not show efficacy against the beta variant, and we are in the middle of the beta variant wave. And to make things worse, all data seems to suggest that the third wave of COVID is coming, and we now need to plan for that. So now what? The questions that are there is, you know, should South Africa continue with the AstraZeneca vaccine? Should it have stopped it to start with? What is South Africa trying to achieve, you know, with this vaccine? Is it trying to stop deaths? Is it trying to stop people from getting, you know, runny nose and sore throat? Is it trying to stop infection? In fact, we don't really know a lot about these vaccines at this stage. How would they even know what needs to be done and how one should respond to that space? That is the question. What does one need to be able to do this? And this is where South Africa finds itself. Now what? Is the vaccine going to work with the next variant that will cause the next wave that we're waiting for? Will it not? I mean, you probably just need to Google in the news to see what the final decision with this vaccine was with South Africa. It, for all practical purposes, never really got used again. So it becomes immediately clear that there's this, you know, this chasm, this gap between science and what we know and the policy that needs to be implemented. There's this gap that needs to be implemented. So over the last 40 years or so, there's been this evolution of how that gap needs to be bridged. And what became a tool for doing that was the emergence of experts who will be able to advise ministries of health. And this became the NITEX that we speak about. And I'm sure that some of you belong to this NITEX, this National Immunization Technical Advisory Groups that are composed of people from different fields, people who come from public health, like Prof. Mohammed here, people like Ilse who come from immunology, who can advise into that space so that the right decision is made. So NITEX have become these intermediaries to assist government in converting evidence into policy. But what is important is when you start thinking about that evidence, start thinking about that, you need to realize immediately that you need a very clear alignment between the problem to be solved, the burden of disease, the science that talks to that, as well as the implication of that implementation. So what does evidence need to look like? It needs to address the issue of disease epidemiology, the burden, including the age, the mortality, the morbidity, the social impact. You need to worry about the clinical characteristics of the disease and, you know, disease severity, the implications for primary or tertiary care, ICU beds, the long-term complications, which at that stage with COVID, they were not even known. And then you need to worry about the vaccine itself. You know, the characteristics of the vaccine. How effective is it? How efficacious is it? What is the impact on the population and different population subgroups, those who are HIV infected, the elderly, the young children? You know, as you heard from the last the previous talk is that immunity may be very different in different groups and different populations of people. And then you also need to worry about what the economic considerations should be within that space. And other issues that are also as important is the health system's opportunities, the social impact, and the legal considerations, and the ethical considerations. We'll talk about this as we go, because those things become key, and they became key in the South African context. So, as a general rule, some of the framework for making those decisions, the evidence that need to be available to allow these decisions to be made, need to worry about this: clarity on the burden of disease, meaningful effectiveness threshold for the vaccine, safety of the vaccine in the target population, the cost effectiveness, and other things, competing immunization priorities. If you're vaccinating against this disease with this number of doses, what are you taking away from the healthcare system? And then you need to also worry whether meaningful coverage of the vaccine, there is any evidence that you can cover. And if you don't cover a certain threshold, what will be the impact in that space, and so forth. So these things become so important with respect to what you mean by evidence. So what do you mean when we're talking about this issue of evidence? Evidence needs to be made to be, it's not something you want to thumbs up. You want to be conscious, you need to be quite explicit in being able to use the best available current evidence to make the decisions that will ultimately have a huge impact in the population, first at individual level, but will also have implications for the whole public health and for the whole well-being of the population. And for that, things that started mattering is, how then do you decide what the quality of that evidence ought to be? This is an image that just shows the hierarchy, that not everything has got the same weight and quality as far as forming the foundations on which to make solid decisions in making public health considerations that will have a huge impact on the well-being of a country or nation. So, as a minimum, you want that all the data that you use to be a summary of all the evidence that is available. You want it to be unbiased, like someone is not nitpicking what they like and what they don't like. You also want it to be transparent, that someone can actually go and find out that the decisions that were made in a certain kind of way, and they hopefully can also replicate that if they follow the steps that someone has made clearly and transparently, and that the data that you get is actually up to date. And that is why if you look at this pyramid, you realize that at the top of that is that those systematic reviews, in particular the ones with meta-analyses that are able to pool the data to get the best of what I've just mentioned now, summary of all the evidence, unbiased, transparent, and up to date. And that's what systematic reviews are supposed to be all about, enriching that end and that goal. And that, with systematic review, in the case of vaccines, gives us what we call evidence-based vaccinology, where the data is identified and appraised appropriately to give the evidence. And there is advocacy for that best evidence of the use of the data. And then you also know what's happening virtually with that vaccine from the whole stages of development for you to actually feel that you are standing on solid ground as you make those decisions. I will not go specifically into how one does systematic reviews, but to show that this is foundational and critical in terms of the kind of data that is solid to be used as evidence. If one is looking for this kind of evidence and data, the so-called Strategic Advisory Group of Experts of WHO, which is also known, goes by the acronym of SAGE, is probably one to look at how one sources and goes through a tranche of a lot of noise and a lot of information out there to synthesize what I was talking about, which is solid grounds on which to be able to make an advisory, and a decision. There's all these steps that SAGE will go through. If now this is something that you'll find on the website, for example, going the whole way from finding out what the problem is, going through all these stages, drafting in the initial and kind of a summary of the data, getting a final draft, and eventually making it to what you'll see as the position papers of that you'll find as WHO position papers. The NITEC Support Center at WHO has been very, very helpful in collating some of these things, including data that would have come from other NITECs that may have looked at the same problem, but having gone meticulously through all the information which is there to then be able to create solid grounds for making decisions. So here we are, as I started from the beginning. What grounds and what will need to change for one to be able to think about evidence in that space? The example I've just given now is probably one of the first classical ones. You have a new disease. You've got something that is unprecedented. COVID-19 would have been that. Of course, we had some kind of potential testers of what it could be, but they kind of fizzled out with both SARS as well as MERS. That never really grew into that. Fortunately, they gave us a bit of foundations on which to start thinking about different platforms for vaccines and what we could potentially do that allowed us to be able to bring new vaccines very, very quickly into the market. But what is clear is that as that data emerges pretty quickly into that space, one needs to then think very, very quickly about how to make sense of that data in such a way that that data can form the evidence basis on which to make solid, defensible, again, transparent and up-to-date decisions as you go. So new diseases are part of that will demand that someone should move fast. And the reason why this becomes important is that in the beginning, one may not have enough data to have that filtered, collated information. You may be working right in the bottom of that chain because that's basically all you have at that stage because you haven't had yet a chance of getting enough studies, maybe 1 or 2 studies. And one needs to be able to make decisions based on that as the best available evidence that one has for making a decision at policy level. So the same decisions had to be made with Ebola, for example, with needing to vaccinate healthcare workers and military personnel that were deployed during the outbreaks that we saw in West Africa, as well as in the Congo, in the DRC Congo. So these are important things that need to be considered as to what evidence would you accept given the situation. And new diseases are some of those that make it very difficult to have the very solid top of the level kind of evidence that one may want to have. Secondly, I think what is also important is to realize that all the same disease for which a vaccine is there, and Corinne did allude to this, where suddenly the epidemiology, either as a result of other developmental issues or as a result of the impact of vaccination, the epidemiology changes, necessitating a review to changing the schedule. But again, that needs one to use evidence to be able to support that. And again, that evidence is aligning those bridges that you remember I showed right in the beginning. You still want to worry about the epidemiology of the disease. You still want to worry about the efficacy of the vaccine and making sure that by changing the schedule, those two things remain aligned in that the schedule to which you're changing in order to deal with a different epidemiology of the disease is still solidly founded on the best evidence that is available to do that. If you look in a number of countries, for example, in the world, with urbanization and so forth, the epidemiology of things like hepatitis A, for example, have changed from where there may be no immunity gap because all children will get infected, but as the endemicity of hepatitis A reduces in those areas, the immunity gap increases, pushing severe disease into adulthood, where it's actually much worse. And as a result, there may be a need now to start thinking about evidence to intervene into that space in a changing world. An important thing is also to realize that evidence emerge that vaccine efficacy may have been poorly understood before in terms of the longevity and duration of the quality of immunity that is there. So I'm just giving an example here of yellow fever vaccine. Before, we all had to have our yellow fever cards and then get new jabs every 10 years because that was the advice. But now what we are now starting to understand, and this advisory from WHO, is that a single dose of yellow fever vaccine is sufficient to protect one for life. The same thing as hepatitis B. Before, we used to check those immunoglobulin levels, and if they are below a certain threshold, you needed boosters. But the memory that Lisa was talking about has been shown to be more important, in that as long as you responded once, if you then get exposed to hepatitis B, your amnestic responses will respond quickly enough to contain the infection without you even noticing that you actually came across anyone with hepatitis B. So we understand now that there may be no need for having repeated boosters throughout life. And again, that has emerged as evidence, became the foundation on which these decisions are now being made into the future. Again, we should realize that the issue about evidence and changing disease profile does not only apply to efficacy and effectiveness of vaccines, but also, and even as important, on safety. Vaccines can have side effects. Vaccines can have side effects that are initially unknown, but that may emerge as they're rolled out. And more importantly, as they're rolled out into different populations than where they were initiated, whether into children. And I'm just giving an example here of what started showing as some signals with young men needing to be concerns about whether you need to worry about myocarditis in young men if they're receiving messenger RNA vaccines. The same thing with the adenovector vaccines for COVID when it came to young women of childbearing age with respect to thrombotic phenomenon and so forth. And this is again what is so important. And so the reason I mentioned this is giving, for example, the example of the Philippines with the dengue fever vaccine, is to understand that evidence does not end with initial trials, including phase 3, and evidence does not end with the licensing of a vaccine. That is why issues that part of these webinars will cover, which is issues of surveillance and so forth. The surveillance is not just for the disease, but it's also for potential adverse events due to a vaccine. And that becomes even more important when it's a new vaccine, in the sense that a vaccine that may have adverse events of, let's say, 1 in 10,000, those adverse events may not be picked up at a phase 3 trial that maybe has recruited only 30,000 people with 15,000 in the intervention arm, for example, because there may only be 1 or 2 cases that may be seen as in keeping with normal frequencies of the disease, of that phenomenon in the population. But once you start giving it to 3 billion people, 1 in 10,000 becomes a very significant number. And if that needs noted, or if, for that matter, there's evidence that it actually exists in a certain group of the population, it may very well be the grounds on which to change policy in order to respond to that changing space of adverse event. In the same time, I think what we started understanding is that the epidemiology of disease may impact in how one uses the vaccines that are available. So, for example, I'm just giving an example here of measles, and I'll talk a bit about it. Here, it's an old disease. Vaccines are already there. Has the epidemiology changed significantly for us to start thinking about how we use those vaccines differently? And is there enough evidence to do that? I mean, measles, for example, is one of those classical examples where when more and more countries reach higher levels of vaccine coverage for measles, and you end up with a situation whereby women of childbearing age would only have any immunity derived from the vaccine, that they may not have as high immunoglobulins as those who may have been exposed to natural infection. They may not have had natural boosting or prior infection. Does that change when you give that vaccine? Can you give it earlier? Because it means that once you reach a certain level of vaccine coverage, maybe more children being more at risk earlier than later. What are the implications for that? Should you, for example, if you've got high levels of endemicity, push it a bit later in order to allow the immunoglobulins in the maternally acquired immunoglobulins to reduce so that the vaccine can be effective? Should you give one dose earlier but not count it dose 0 in order to make up for the fact that you still want those who may not be protected to be protected, but then still give them a chance of mounting natural immunity, I mean, their own immunity against measles? Those things become very, very important. And there's an example of pertussis here is what we started understanding. All disease, all vaccines, so to say, and then data emerging that as the disease now is being seen in adults and adolescents who then become carriers and reservoirs for small infants, that vaccinating their mothers, for example, makes a big difference in protecting infants before they've received the vaccine dose themselves. That is a change in both epidemiology, but now leveraging on emerging evidence for being able to use the same vaccine for an old disease. And you can see as safety data comes through, then suddenly, boom, we can actually go to the top of that pyramid by starting to have meta-analysis and systematic reviews as the evidence accumulates into a space that would have been seen as old and as not new. And you can see with this conclusion, there's now an increasing body of evidence to support the safety, immunogenicity, and the effectiveness of vaccinating pregnant women. That is basically what foundations for evidence-based vaccinology does in terms of giving one a solid grounds in which to make new recommendations, introduce new schedules, but still dealing with the same diseases and with the same vaccines, but in a changed epidemiological space. And I think that's quite important to be able to do that. This also speaks to, as I said, to other schedules like Corinne was talking about. It may include the mixing of vaccines, which other people are asking about, whether you can use this vaccine and that vaccine. It may include combining vaccines from different manufacturers, even if they're the same type of vaccine. And we've seen that with the recent COVID vaccines. And usually this may happen again at phase 4, which again gives us a very clear indication that data and evidence cannot be limited to lower phases of studies, but phase 4, and when you are in full implementation, your surveillance and your understanding of what happens in the real world becomes part of the of that evidence. I'm about to finish now. So I think it's quite important to realize why this is important. And I say this in conclusion, that sound evidence, even in a changing world, is perhaps the best tool we have to defend against lack of vaccine confidence or outright vaccine hesitancy or even anti-vaccine sentiment, which may be there. Because one will need to be in a position to defend the decisions that are made. And sometimes this comes to be as terrible as having to defend decisions, even in an emergency where decisions have been made almost, on the fly against litigation. I mean, I'm just giving this newspaper clippings here where there is, where there are have been court cases that were thrown out of court when people were trying to hold the advisory to vaccinate adolescents, because the decisions themselves had gone through the rigorous process that we have spoken about now. The evidence had been generated meticulously, transparently, and in a way that's replicable if someone should look at that. And that gives the strong foundation in which to be able to defend things like litigation and criticisms of bias and so forth. So I think I will stop here. And I hope that was just helpful to just highlight the importance of vaccine, of evidence-based vaccinology. I would like to leave more time for talks, because I think this was when we were supposed to have been ready to do so. Hassan, let me stop here. Thank you.
Thanks.
And again, thanks, Ben, for some of the slides that you've given to me.
Thanks so much, Lutsani. That was very, very useful, and that was very interesting. And thanks for taking us into this space of decision making. So I'll just put my video on briefly. You know, decision making can be a complex, a difficult area where science meets with policy decision making, and it can be a difficult space to navigate. But you provided some very useful advice in terms of what we should be doing, how we respond, you know, despite the fact that there will always be, you know, ongoing challenges, particularly, as you said, with new emerging diseases where the data is still emerging. We're going to go into a question and answer section, and I want to respect the questions that have been asked. If we can go to the first question, and yeah, so this is from Denis or Denise or Dennis. The question for, I think it's directed at Karin, but I think Elisa can also perhaps comment on this. It's the whole question of heterologous vaccines. So if you take one vaccine of COVID, should you take a different vaccine as a booster dose? You know, there have been some instances of this. What is your response? So, Karin, do you want to start with trying to answer this question? And then I think Elisa can also contribute, I think, usefully to this.
Yeah, thank you for that question. And indeed, this is what is happening in Belgium, in other countries, that you start the COVID vaccination with one of the vaccines and you complete it with another type of the COVID vaccine. So starting with AstraZeneca and then have a Pfizer booster has definitely happened. Also starting with Johnson & Johnson vaccine and then the Pfizer or Moderna booster, that definitely has been happened. And it seems that this heterologous prime boost that gives a stronger immune response, but that is for Prof. Elisa to further comment on it if possible. Thank you.
Yes, Elisa, I think, you know, this is really about the complexity of the immune system, and yeah, what are your comments?
Thanks. I'm a huge fan of heterologous vaccination, and okay, the disclaimer is that there have not been many studies that have systematically addressed this question. To go back to, you know, Rushdani level of evidence, there have been some, and now I guess, you know, as the war that is combining vaccines, I guess it's difficult to do head-to-head comparisons, but the point is that you can still say, well, there is no increased safety risks. That's the most important thing. And the levels of immunity seem to be protective. But there was one study that came out as a preprint last year, and the next day I ran to get my Pfizer, I can tell you that. And then it was published more recently on the New England Journal of Medicine. But it does look like heterologous prime boost could give you better immune responses in terms of antibodies, but it depends on the combination. So if I'm allowed to go into something a bit more technical that I didn't cover, but different types of vaccines, as I mentioned, would skew the immune response differently. So generally speaking, all the viral vector vaccines, so your AstraZeneca and J&J, theoretically are better at inducing T-cell responses and CD8 responses. And the reason for that is that because these are kind of mock viruses that don't really replicate in the body, but they infect for one cycle target cells. So your skewing of your immune response is giving a signal, oh, this is an intracellular virus, I need a CD8 response. So it's very simplified, but the viral vectors are particularly good at inducing T-cell responses. While the mRNAs, they also go inside the cell, but maybe they give different types of danger signals. So I think they also induce a T-cell response, but they're kind of better at inducing neutralizing antibodies. So from the immunologist perspective, and from what I told you about what the thinking and the emerging data is, that you need a different type of immune response to stop the virus at different stages. So you need antibodies to stop or contain initial infection, and probably you need T-cell response to stop progression to severe disease and death. Personally, I want them all. So if combining different products that are made to be better at inducing a certain response to another, it gives me the idea, which is partly backed by the current evidence, which is still very early days, but it gives me the idea that it broadens the tools that your immune system can use against the same pathogen, but at different stages of infection, progression, and disease. So I'm all for it, but there is more need for evidence. But again, it does. I mean, billions of people have been now vaccinated, and there hasn't been a safety signal particularly related to combining different products. So to me, that's the most important thing. And clearly these combinations work. So that would be my take.
And I see Rudzani's raised his hand as well, and I was going to go to him because this is kind of also a question of policy. You know, how does one actually navigate this? I mean, Elisa says it out very nicely. The data is emerging; it's not final. And I've also seen a number of articles where, you know, it's suggestive that combining COVID vaccines with different types actually gives a better immune response. But of course, it's still early days and it's short follow-up period, and one doesn't know. You don't have data on whether this persists in the long term and what happens over time. So the evidence perhaps is incomplete. So what do policymakers do? So Rudzani, you're going to help us with that.
I just wanted to add that you know, it's been a very rapidly changing space. I know when you look at ACIP data and CDC, for example, they've almost encouraged it in those that may have received the J&J vaccine, which was the adenovector vaccine that they've used. They basically make a preference a messenger RNA follow-up than another adenovector vaccine, because the feeling is that the evolving evidence is very much skewed and in favor of the heterology in that case when you have started with an adenovector vaccine. But I also wanted to just point out that also what is interesting, and we may have to figure out how to deal with this, is that an interesting heterology is that of between a vaccine and natural infection, where the data that is showing now is showing much better quality and duration of immunity in people who had both a vaccine and may have been infected before or after that vaccine. And that may even become important if we're trying to encourage a very hesitant community to just say, you just need one dose. You just need one dose if you were infected. And people, and this is basically what we just need to think about. Let me stop. I think Elisa has got something to say.
Yes, Elisa, you want to follow up?
Yeah, if I can add one thing that for now is just theoretical, so it's zero database, but the other possible advantage of heterologous vaccination is that, you know, when you use something like a viral vector, your immune system doesn't make the difference between the vector and the insert. So you would develop an immune response against the vector also. And so, while I don't think this is possible with the mRNA vaccines because of the way they're packaged with liposomes, which is like lipids. So as I told you, you don't really develop an immune response against lipids. So I don't think that's an issue for the RNA vaccines or for the proteins, but for the viral vector, definitely is a concern. And so that would also be a rational basis to say if you had a prime with a viral vector, you rather boost with something else, because the immune response that you may have induced against the vector could actually stop the vector, or if you give it again as a boost, from doing anything. I'm not saying this is not supported by data, but it is like a biologically plausible thing, and it's something that has been observed like in clinical trials for maybe other vaccines. So the immunity anti-vector could be relevant, and that might also be why, you know, for those who received a viral vector, some of the regulators have said, okay, move to RNA.
Yeah. Thanks so much. Thanks to the panel for all the responses, and thanks to you, Denise, for putting forward this question. It's generated quite a lot of responses from our colleagues here. From Amadou, there's a question about what about rotasil, and I think Karin, this relates to your presentation when we were talking about the rotavirus vaccines, and you initially mentioned, I think it's Rotarix and Rotatec, but I think you did go on to mention rotasil. Is there anything more that you'd like to add, Karin?
Yeah, indeed. So I just started that discussion on Rotarix and Rotatec because these were the two rotavirus vaccine first available. And more recently, Rotavac and Rotasil has been WHO pre-qualified, and they are now also being taken up in the WHO position paper with recommendation. For Rotasil, it's a 3-dose schedule orally, 4 weeks apart, starting at 6 weeks of age. And the package insert says that it should be completed in the first year of life. Now, with the new recommendations from WHO, actually to firstly have these age restrictions and then open it up a little bit, they of course still recommend to start as soon as possible from 6 weeks of age, but you could give the rotavirus vaccine up till 24 months maximum of time. So that would mean for few of the vaccine and off-label use, but it is being recommended by WHO. So it's for Rotasil. Thank you.
Can I just ask you as well, Karin, as a follow-up? You know, you said this is a 3-dose vaccine. The existing vaccines like Rotarix are 2-dose vaccine. So what's the potential advantage of introducing a new vaccine like Rotasil? What might be the advantage?
That's a good question. I don't know.
I'm putting you on the spot a bit because, yeah, I mean, I think yes, these are relatively new vaccines and we're still learning about them. But yeah, I think that's perhaps a question, a policy question that might need to be asked. And so I'm going to put Rudzani on the spot. When you've got different options, and we've had that with COVID, you know, what would you look at? How would you judge which vaccine you'd want to go for when you've got, you know, different options available, Rudzani?
You know, quite often these have always been very difficult decisions, and I think Greg will probably chip in here. And a number of decisions have been based on the cost and cost effectiveness, which is where the other things come in. Secondly, on the availability of that of those vaccines. So, for example, although we have got all COVID vaccines out there in the world, we don't have, you can't give Moderna in South Africa because it's not registered, because Moderna has not registered their messenger RNA. And then thirdly, it may be because there may be funding bodies who are sourcing that for your country. So for example, if we are Gavi funded, you probably will have as much choice as what Gavi is able to source for you in a sustainable manner. Then the last thing, which is where the difficulty lies, Hassan, is the fact that, I mean, when you're talking about rotaviruses, for example, the initial studies showed very well that the vaccine efficacy is not the same in the UK, in Malawi, and in South Africa. So technically, there may be different aspects based due to other things that I don't think Elsa touched on this, which is your microbioflora, and different people, especially with live vaccines, may have very slightly different microbioflora that influences how their immune responses are with what they identify as foreign and as antigenic. So these are the kind of things, but unfortunately for most low and middle income countries, trials are not available in their countries. It's one of the terrible things. I mean, if we did not have the AstraZeneca trial here, probably nobody would have figured out that there was a difference in how different strains are covered by the vaccine. And I think that's quite an important thing. Let me defer to Greg.
Okay, Greg, do you want to comment on this issue?
Yeah, so just a brief comment, Hassan, and thanks to all the presenters for wonderful overviews. So there are two rotavirus vaccines that are currently used in Africa: Rotarix, which is a 2-dose schedule, and Rotatec, which is a 3-dose schedule. Okay, so Rotasil is the difference between Rotasil and the others is in fact the unique feature that Rotasil is heat stable. So we know that both Rotarix and Rotatec vaccines, like most vaccines that we use today, require a well-organized cold chain. And Rotasil has been developed to have that feature of being heat stable. So it can remain out of the conventional cold chain for long periods. So it's extremely useful in getting that vaccine to populations that are hard to reach. So it's a 3-dose schedule, similar to Rotatec. And just as a matter of interest, the other that many people around the table will know, especially those who live in the meningococcal belt, is that the MenA vaccine that was developed to control meningococcal A outbreaks in the meningococcal belt is also a very good heat stable vaccine, so it can remain for periods outside the conventional cold chain. So those are two excellent vaccines, Rotasil and MenA, both developed in India. Good for them. Sure. Thanks.
Thanks so much, Greg, and that's a very useful contribution. And I mean, I think contributing more generally to the whole issue of decision making, one can hear that, you know, there are a number of factors that need to be considered. And in this instance, the fact that this vaccine is heat stable gives it an advantage. And that's why it's something that's being seriously considered. So thanks so much. Let's go on to the next question. So from Mohammed, combination vaccines are a very good initiative. However, is there not a possibility of potential interactions between different components of the different vaccines, especially with the inactive ingredients? So, Karin, perhaps I'm going to start with you again because you've raised, I think, the question of combination vaccines, but I think we can ask the other panelists to comment on this question as well. Karin?
Yes, thank you. Well, regarding potential interactions, the different components, maybe I leave that specifically to Elisa, but I can say that for the combination vaccines, each vaccine, whether it is a monovalent vaccine or a combination vaccine, is being tested for safety, quality, and efficacy, and it is being registered as such. So also a combination vaccine needs to be safe and have good quality and good efficacy. The approved combination vaccines, they need to produce equivalent seroconversion, seroprotection rates as compared to the monovalent vaccines. And each component vaccine should be compatible and will not decrease the effectiveness of the others included in the combination vaccine. And the combination vaccine should also not increase the risk of adverse events above that of the individual monovalent vaccine. So that I can say in general, probably more detailed feedback can be given on potential.
Yes. Yeah, so I think what you're saying is that there are additional studies that are done just to ensure that when you combine vaccines, that there are no additional adverse effects and that efficacy, is maintained. And so this is looked at when combination vaccines are put together. Elisa, do you want to comment on this?
Not really. I think I'm not a chemist, and I would have given the same answer. I mean, but all of these are, I believe, vaccines for which a correlate of protection is known, and they would have been tested against the correlate of protection, and probably like in big population studies once they are rolled out. So it could be a concern, but it's addressed before they are licensed.
Yeah,
I don't have more specifics.
Yeah, no, I'm aware of studies where vaccines combinations don't necessarily work, or there is an impact on the efficacy of one or the other of components of a vaccine. So it's definitely, it shouldn't be assumed that when you combine vaccines that everything is in order. It does need to be evaluated properly. Rutsani, please do comment as well.
I just wanted to say that apart from the issue about efficacy, is the other issue that I probably alluded to, which is the issue of adverse events. So for example, we know that MMR used separately with the varicella separately, as opposed to MMRV. MMRV, when used in combination, the interactions that is happening in that combination has got much higher rates of rashes and febrile convulsions and so forth that are much higher than when those combinations are separately given. So it, again, it's one of those things where, Hassan, as you're pointing out, it's very important to try see vaccination combinations almost as a trial on preparations, not just on the fact that you know what happens with the monovalent preparations, because I may not tell you what happens when they all come together. Yeah, thanks.
Thanks, Rutsani. Elisa, I see you have your hand up again.
Yes, I have a follow-up question actually for my colleagues. I was quite shocked when Karin showed how many people just make up their own vaccination schedule. And like as a follow-up, when we say, oh yeah, no, all of this is carefully tested, which is true. But then if, of course, people have free will, and if they mix and match vaccines as they please, it's just a general question, you know, how many of the healthcare workers that administer the vaccines outside of the schedule are actually aware of some studies, or what Rusdani just mentioned about certain combinations that should not be given together?
Yeah. Karin, that's an interesting question. I don't know how comfortable you feel with responding, but do you want to give any comments?
Yes, that is indeed a good question. It is shocking to see in that study that I showed that 25% of the people just say, well, I don't want to receive 3 vaccines today, only 2 today, and then I'll come back later. And indeed, it is. It would be interesting to know how the response. It seems here that the healthcare worker agreed to it, which is indeed a very scary. To understand that, because they should explain to the caregivers, to the people, why it is important to adhere to the schedule, and indeed don't mix and match just at their own as they please. So maybe we can start some new studies on that. Maybe care workers.
Yeah, this is the whole issue of, it's all very well doing the studies, and then there are all the operational challenges. And I mean, this would be obviously a training issue, and, making sure that the vaccinators understand. I mean, what happens in practice is challenging, because often health workers are faced with unusual or unexpected situations. But they need to know how to deal with those, to consult, to get further advice from experts if they're not sure what to do if they are uncertain. So it's not necessarily having all the answers, but also knowing what to do if you're faced with an unusual situation. But thanks for adding that additional question. Greg, I don't know whether you want to add to this issue of combination vaccines and potential interactions. Any word from you?
His hand is up.
Yeah. No, I was trying to put my mute button off and I pressed my hand. No, there's nothing. Enough's been said about it. I mean, the bottom line is that combination vaccines generally are safe. I mean, I think the only one that is a bit of a problem is the one that Rudzani referred to, the combination of MMR-V. But generally speaking, the others are fine. And giving multiple vaccines at the same time is also okay. So I think the big issue is, how many injections can a child tolerate? So I think we're all still searching for the Holy Grail, which will eventually be one injection or one oral drop that will include all the antigens. But maybe that's in another lifetime.
Yes, obviously. Thanks so much.
I just wanted to say,
yes.
Sometimes you do get assistance from regulatory bodies refusing to give licenses for things to be given together. So Greg, when he was chairing NAGI, for example, is the time that Sanofi withdrew their measles vaccine. So we had to find Miss Bio from, I think, Indonesia, and forcing the South African schedule to be changed to accommodate the 6 months and the 12 month schedule in order to separate Miss Bio from all the other antigens, because the decision by SAPRA was not to regard lack of evidence for adverse event as absence of adverse events, so to say. Yeah. And I've had one child who was given that, and they had a fever. I don't know if it was just bad luck, but it was the only child that actually someone was trying to catch up with the measles vaccine and other things at the same time. And the child had quite a swollen limb and fever after the combination. But that's when one place where the where the regulatory bodies may say they are not issuing a license for a certain vaccine to be given with others, but people may still get around that if they get hold of the vaccines themselves. Yeah.
I remember this issue, quite well, because I was involved in the operationalization of introducing Miss Bio, and it raised a lot of questions because it involved extra visits to the health facility by parents, just because of this, change in policy. And I mean, Karin speaks to the comment that you raised about measles vaccine, which was originally given at 9 and 18 months or something like that, or 9 and 15 months. in South Africa, and then suddenly it got changed to 6 and 12 months with MEAS Bio. And in fact, you were suggesting that that's inadequate, that the 6-month dose should be regarded as measles 0, and that the first dose should be the measles 12-month. And in fact, we should be giving another dose of vaccine. So, I mean, for colleagues on the call, obviously we're talking here about the South African situation. So, apologies for that, but I think we're just using it as an example for some of the challenges that might occur when we talk about either combining or not combining, vaccines. But Karine, I think if we can just, I don't want to lose out on the other questions, but just briefly, I think, would you then advise us in South Africa, given our 6 and 12-month schedule, that we actually need to have another measles dose?
Well, that is indeed the recommendation WHO makes. Now, I think if you can prove that you have a good seroconversion rate at 6 months, then the 2 doses is probably sufficient. If you don't have a good seroconversion rate at 6 months, then probably well, a third dose then, but then depending on how you start counting, of course, then an additional dose might maybe be useful. Yeah,
might be indicated. Yeah. So okay, so that's a message to Greg to take up at NAGI, at our national advisory group on immunization in South Africa. But that was an interesting discussion, and thanks, Mohammed, for raising this question. Let's go on to Faiz. And again, Karine, you seem to be very popular here. How did they evaluate the protection of the HPV vaccine? And then there's a second question at Elisa, how to be sure that the predicted protection of the vaccine takes into account neutralizing antibodies and not just binding antibodies. So some nice questions there. Karine, let's start off with you again.
Yeah, thank you. For the trials on the HPV vaccine, it was measured to persistent HPV infection, so persistent of HPV types longer than 6 months, or as the endpoint, the precancerous lesions, so the cervical intraepithelial neoplasia, measured at there are 3 stages, SIN 1, SIN 2, and SIN 3, and the clinical trials have used the SIN 2+, so the later stages 2 and 3. So that is how the efficacy has been measured. So
using the incidence of precancerous lesions on the cervix is the main way in which they judged protection or efficacy.
Yeah.
Okay, good, thanks. Elisa?
I'm gonna give a general answer because I don't know specifically what the correlates of protection for HPV is. Another thing that I didn't go into detail, but that's important, is that there is a distinction between mechanistic correlates protection and not mechanistic correlates protection. So sometimes if we know what is the immune response mechanistically responsible for protection and we can measure it easily, then of course it's a no-brainer to measure that. But in many cases, there are some immune responses that even if they're not mechanistically responsible for protection, they correlate very well. And in that case, we call them surrogate protection. So of course, it all comes from, doing the right studies and measuring multiple responses at the same time and doing some solid statistical modeling. So just like, the operational considerations for rolling out for the immunology lab is the same. If you can measure a certain immune response more easily than another, and it's correlated and it gives you the same answer, even if it's not the mechanism, then you may go for it.
Great. Thanks so much, Elisa. So I see questions sort of accumulating. So another question from Mohammed. Combination vaccines are a very good initiative. Is there not a possibility of interaction? So this is a similar question, especially with the inactive ingredients. Oh, okay. So I think that was added. Okay, let's go on to Joshua's question because we dealt quite a bit with combination vaccines. Thank you for your presentation, Karin. Again, you're number one in the popularity stakes here. I would like to know the quality approaches considered for testing in vaccine, combination vaccines. So again, a bit of a technical question. Well, perhaps let me ask you, Karin, or Elisa, if she can comment, but let's start with you, Karin.
Yeah, thank you. Well, I think, as I said earlier, that for the combination vaccines, they are being tested in the trials for safety, quality, and efficacy before they are licensed. So I think that process is similar as for monovalent vaccines as well. So, but yeah, this is just a general answer. So that for the registration, the quality, safety, and efficacy has been rigorously tested, and yeah, general response.
Look, I mean, I think this probably also refers to the manufacturing side of things and how quality testing is done there. I mean, there are these so-called GMP principles that need to be applied, so general manufacturing practice, so minimum standards that need to be applied for vaccine manufacturing facilities. And I'm assuming that as part of that process, there's not just for single component vaccines, but also for combination vaccines, that there would be the usual kind of, sample testing or, quality testing of the actual vaccines when they are combined to ensure that there's no degrading, and that there would be laboratories that constantly evaluate. And then also, as I understand it, when vaccines arrived in South Africa, for example, the COVID vaccines, our laboratories or our regulatory authority got our laboratories to test the vaccines to make sure that they met certain standards. So I think there are general principles that would apply to both monovalent and combination vaccines, and I'm not sure if there would be special additional testing. I guess, you test all the components of a vaccine. But Greg, I see you have your hand up. Perhaps you want to add an answer to this question.
No, Hassan, I think you've answered the question. I was going to basically say what you were saying. So most regulatory authorities in Africa would, before the vaccines released into the community, would do some specific testing of lots to make sure that the vaccine is safe and can be used in the community. And where this is not available in countries, it's usually sorted out through UNICEF or Gavi-related organizations. So vaccines are procured, as you said, under good manufacturing processes, delivered to countries, and in most countries, in many countries, the individual quality control labs would check them out first before they're released into the community, and do that subsequently as well. Okay?
Yeah. Great, thanks. Let's go on to the next question. And I think just to emphasize that we want to finish our question time by 3 o'clock. Is there a next question? Or should I look at the Q&A box?
Please look at the Q&A box. I haven't had a chance to capture the late ones. Thanks.
Okay, that's fine. So Muhammad Garber has asked, regarding COVID-19 vaccination, which one would you advise based on available evidence when people have all options available? And I think this has been, thanks so much for that question, because this members of the public ask these questions. So there are options available, and I think it's somewhat unusual in any country that we have a number of vaccines available, and that's happened to us with COVID. Rudzani, I mean, to throw this question in your direction is not necessarily to give an answer, but maybe how would you approach an answer to this question? Because I've certainly been faced with it. So let's hear what you have to say.
I think Greg will be the best person. He's a member of our feedback. He's been working on this for a very long time. I mean, this is probably a classical space in which the data has been evolving. I mean, some of the questions we talk about heterology and stuff like that start fitting into this space. For example, initially, and if you remember even the CDC/ACIP advice in the US would have advised, let's say, old people to get the J&J because it was seen as a one-stop shot. You go there, you reduce the chance of them being exposed multiple times, you're vaccinated once, and then you're done. Yeah. Then we started seeing waning immunity. And then in our case in South Africa, you would, even if you wanted one, only the other would have been available, or vice versa, in which case the best vaccine was the one you could get access to. Now, this is a special situation, which is where we are right now. Elisa will have to be asked tomorrow. When she goes to the vaccination thing, she may be asked, which one do you want, the J&J or the Pfizer vaccine? And again, this is where one may have to use the best available data available. I mean, the available data as it were. So it's been very difficult. And one of the most difficult is that there's been very little head-to-head comparisons.
Yeah.
This is where we are right now. And so the things that start mattering may very well be side effects profile. I'm just giving an example. So for example, we know that one stage in the UK and so forth, they started avoiding the adenovirus virus vaccines in the women of childbearing age when both of them were available. So, and then they started maybe suggesting that if they are younger men less than 20 at one stage, that maybe they should avoid messenger RNA vaccines because they were still okay. Even if they are 18 to 20, you could still get an adenovirus vaccine and so forth. So you start trading off benefits and risks, and in a rapidly changing space. So I don't want to be accused of favoring one manufacturer to another, but I'm just saying that this is basically the space where the evidence is changing even as we speak. Yeah.
Yeah. No, thanks, and I think that's a fair response. I mean, I think the one thing we can say is that all the vaccines seem to have pretty good efficacy at in terms of preventing severe disease, and there's not much to choose, amongst them. There is general, variation at Johnson & Johnson. Overall efficacies always seem to come out slightly lower than the mRNA vaccines. But there has been also some argument that the adenoviral vector vaccines immunity lasts longer than the mRNA vaccine. So there are lots of factors to take into account, and there isn't really a straightforward answer. Greg, I don't know whether Ruzani suggested you have an answer to this question. Do you have an answer?
I think both of you have answered it very well. I mean, I think the one thing we don't know, because the vaccines have not been compared with each other. So there's no trial comparing AZ versus a J&J or J&J versus a mRNA vaccine. The trial conditions for the efficacy studies have all been different. The effectiveness data that have come out, they have different methodologies. So you're basically comparing apples with pears. And my advice is to say, these are the vaccines available if there's more than one vaccine. These are the vaccines available. This is the current data that we have with respect to efficacy, effectiveness. This is the potential for significant adverse events with respect to each vaccine. You decide. But I think the important point is that, you know, all the vaccines, I'm not only talking about the common ones like AZ, J&J, and Pfizer, Moderna. We're talking about Sinovac, Sinopharm, Gamaleya. I think most of the vaccines have been shown in studies, and as I said, these studies vary quite significantly in terms of effectiveness data, that they do protect against severe disease, hospitalization, and death. So yeah, take your choice. You decide.
Thanks, Muhammad, for asking that really useful question that is on many people's minds, you know, and often not spoken about. Again, you've asked a follow-up question. In Nigeria, there is so much emphasis on giving HBV, I'm assuming that's hepatitis B, vaccine within the first 24 hours of birth, to the extent that clinics are told to open over the weekend. Is there any immunologic basis for this? So I think, Karin, you referred to this, but maybe just to give you a break, I'm going to try and start with Elisa. And I don't know whether you feel it's a fair question for yourself, but let me start off with you. What's the basis of giving hepatitis B vaccine within 24 hours of birth?
Okay, the answer is that I'm not sure, but after listening to Karin, so maybe I'll give her answer. I think the reason is probably more epidemiological than immunological. So she was mentioning that, you know, the recommendations are made also based, of course, on risk. And if in one area, lots of mothers have hepatitis B, the risk of transmitting to the child is very high. And therefore, even if birth is immunologically is not really a good time to vaccinate, in the sense that the immune system is as immature as it comes, the reality is that when the risk of getting the disease and the infection, severe disease and death is high, you just want to vaccinate at first opportunity. And we do the same for tuberculosis, right? So in different countries is different, but in South Africa, you don't even have the time to do your first screen that you're given BCG. And I mean, we've shown that if you give it a bit later, the immune response looks a bit better, but the reality is that you don't want to miss them. And it's like when you have a child in front of you, it's the time to vaccinate, and then you never know if they will come back. So I think it's mostly an epidemiological reason more than an immunological one.
Reason, yeah. Lutsani, you put on your video. Do you want to?
I was going to say partly what Elisa has said, which is exactly that. That is probably, if you look at all vaccine coverage, the highest you get is when you give peripartum doses for BCG. From then you start kind of declining. And so WHO has recommended birth dose for the African continent because of the endemic and high burden of hepatitis B that may occur in the first 1-2 months before the first dose of vaccine is actually given. However, the reason why, for all logistical purposes, you're getting all people working on weekends and stuff like that is because of the pressure that governments feel to show statistics to WHO that they are actually delivering on an agreement. It's the same thing with you know, polio eradication programs, with you know, surveillance, and you know, you find that people are quite under a lot of pressure, and South Africa has been under a lot of pressure too to introduce a birth dose to align itself with WHO protocols, even though the NITEC in South Africa may have been less supportive of that, given a slightly different epidemiology of hepatitis B infection. But the main reason for the push is to politically align with the WHO from the Ministry of Health, and that is basically, I think, what is happening, but on the basis of epidemiology. Yeah. Thanks
for adding that. And yeah, political considerations are there, you know, for an alignment. Those are also issues that are on the minds of policymakers, you know, even if those of us in the science or research field don't always see that those are realities for policymakers when they've got to make decisions. Karin, let me just check with you. Anything you want to add to what's already been said?
No, there was a perfect answer. Everything was included. Yeah. Thank you.
Okay, good. Next question from Julie Copeland. Thanks for all the great talks. Do we understand the biological reasons for the difference in immune responses to HPV vaccine at the different ages? Why should slightly older groups require an additional dose? And yeah, I did find it interesting, Karin, in your presentation, but I see that Elisa has put on a video, so let me ask her to respond.
Well, I wanted to trade with Karin because I answered her previous question. She can take this one. But I mean, I don't see an immunological reason when you compare 10 years old to 20-something years old. It might have some reason if it's much older women, but like senile women. So I'm really not sure at that small range of age. And I'll pass it to Karin.
So Karin, you put it in your presentation, so I suppose that puts you under obligation to give some sort of response.
Yeah, but what I can also only say is that it was clear that in the younger age group, the data I showed for the bivalent vaccine, and it's really similar for the quadrivalent vaccine, that the immune responses in the 9 to 14 years old were much higher than in the 15 plus group. That was the reason with the schedules to give 2 doses in the younger age group and 3 doses in the older age group as the immune responses were lower. But why there is a difference in indeed such a close age group, actually, I also
Look, that said, I don't know for HPV, but there are super interesting differences in immune responses between men and women, and how puberty and sexual hormones can affect those. And I would say that there are people who look at it, it's kind of a new field. So I don't know, I guess, everything, as you say, is data driven. If there are higher immune responses with those doses, then that's what you go for. As to understanding the mechanism, we don't understand why, but that could be one thing. But again, it's just an hypothesis. I have no idea of the data.
Thanks. Julie, you've stumped our panel. Congratulations for doing that. But yeah, we don't have all the answers, and you're right, that was an interesting observation about that difference. So it's something that needs investigation, and as Elisa said, that it is being investigated. So coming to the last question, and we won't really have much more time after this. Thank you, Professor Rudzani, for this presentation. I imagine that the decision-making process is not easy, especially at the national level. I'm curious to know if the decisions in the different waves of COVID-19 were made by an ad hoc committee or in combination with political authorities. How much freedom did public health and scientists have? Thank you, Amadou, for that very interesting question. And yeah, I think Rudzani's that's a nice question for you, Rudzani. What do you say? Rudzani?
I'm trying to unmute myself. Especially at the next, so no, Greg will tell you that there have been some decisions that may have been made on the fly before a whole panel was asked to engage with some of the aspects. But I would say, if I'm not mistaken, Greg, that the process has become much better refined with respect to an advisory group that has been constituted with a formal letter of appointment from the Minister of Health into those committees. That's basically where things are. And I think people are very much open and defend their space as academics in that. There is obviously a need to be practical by bringing in logistical things of policy alignment and logistics that are feasible than just being a theoretical scientist who seems to be working in a vacuum. Otherwise, you can't achieve much in terms of getting advice into practical policy. So there are some of those things that are taken into consideration, but by and large, my sense would be that the committees would be given the freedom of making those scientific inputs. Greg is, again, would be the right person to respond to this than me.
I think you're being very diplomatic, Rutsani, in your response. But Greg, give a more honest opinion about what actually happened.
What actually happens? I can only talk about South Africa, so I can't talk about the rest of the continent.
I think the question is, yeah, but I think it's of general use anyway. Yeah.
I mean, in South Africa, there is a ministerial vaccine advisory committee that operates outside of the National Immunization Technical Advisory Committee, although there is some membership that straddles both committees. And in essence, from the first wave through to the current wave, the decisions as to who gets vaccinated, what vaccines we use, have been debated and discussed within the committee. The decision as to ultimately what to do rests with the Minister of Health.
Yeah.
And I think the same practice applies to most other countries on the continent. In a number of countries, the decisions on what to do with vaccines for COVID-19 disease or prevention of COVID-19 disease have been made by national immunization technical advisory groups. In other instances, they've been made by ad hoc committees that have been more or less constant. This has created a bit of tension, and we certainly know in one or two countries there's been a significant tension between these ad hoc committees and the National Immunization Technical Advisory Groups. And then just to say that in countries that lack capacity with respect to expertise, they tend to lean on surrounding countries or the advice in terms of support and decision-making comes from the WHO Afro region. And there is a regional immunization technical advisory group that provides support on the continent generally. And then there's the WHO Geneva that ultimately makes recommendations for countries to follow if appropriate for their needs.
Thanks so much, Greg. I mean, I think the process was complex from what I could see. I mean, the scientists were advisory in their recommendations. They gave advice to government, and I think it wouldn't be correct to say that they made the decisions. And then it was up to government to decide whether they would adopt those, and they didn't always. And I think, again, I'm being frank from my side, that governments don't always adopt the decisions of the scientists, but I think it was positive that there was a scientific group set up by government to give them advice. I think that there was an attempt to be evidence-based in the decision-making. But the reality is that, you know, I mean, I think there are multiple forces working on government at any one time, and that makes the decision-making process not as straightforward as we would like. So on that note, I just want to thank all the panelists. If you can just put on your videos, Karin, Elisa, and Rutsani. I think you gave excellent talks. They were really, really impressive. And thanks to all the people who asked questions. They were really very interesting questions, stimulated a lot of discussion. I want to thank all of you. Thank you, Greg, for also contributing as an honorary panelist to the discussion. I think that's appreciated. But thanks so much from my side. And I think just to end off, I guess I hand back to you, Ben, just to make concluding remarks. And I think we will be in time. I see it's 1 minute to 3 to finish our discussion on time today. Thank you.
I'll just jump in and do the conclusions as a VACC member, so that Ben doesn't take too long to come in.
Okay. So
again, thank you very much for sharing this session. I just want to again say thank you to all of you for joining this meeting. I'm putting the slide there so that you can just see that if you need to give us feedback, please email us at vacc@uct.ac.za. We'll really, really appreciate your input. But I just want to acknowledge and thank all my three colleagues, the two speakers, together with who covered the webinar today with me, as well as Hassan for being here and for excellently chairing this session. Thank you so very much. And I just again thank you, all of you, our annual vaccinology course alumni, for spending this time with us. And I just also want to thank Pfizer, who have supported this work by giving us an unconditional educational grant to allow us to be able to host this series of webinars. And last but not least, I just want to thank our VACFA team, for working behind the scenes and putting this together. Thank you so much, Naina, Edina, Salim, for all the technical inputs that we really appreciate, and Chantel, who has been in touch with all our attendance to this meeting. So thank you very, very much. I think our next webinar is scheduled for the 6th of May, Ben, if I'm not mistaken. And so really hoping to see you in the next installment of this series of webinars. So thank you very, very much, and a lovely weekend ahead.